Hello, everyone, and welcome to the Innovative Approaches to Clinical Care webinar series. My name is Chloe Bernard. I am a manager on the Healthcare Access team here at NASDAQ, and I'm delighted to be joined by my colleague, Sarah Palmer, who is also a manager on the Health Systems Integration team here at NASDAQ. A few housekeeping items before we begin. We ask that as you enter the room to please remain on mute. If you have any questions as we are going through our presentations today, feel free to drop them in the chat box, and we will save some time at the end for any questions that you may have. Finally, the webinar is being recorded, so we will share the recording and the slides with you at the end of the session. Thank you all for joining, and we look forward to hearing from you.
Probably nothing you need to go on. You're probably fine.
If you will, please, as you are joining in the room, if you will, please remain on mute. Thank you so much. Next slide, please. A quick disclaimer that this project is supported by HRSA as a part of a cooperative agreement that does not necessarily reflect their views. Next slide, please. And so today, we will start off by sharing a little bit of our agenda for today. And here is our agenda. So we'll start by sharing our learning objectives for this webinar, and it will be followed by a brief icebreaker. So get ready for that. We will then provide a high-level overview of NASDAQ, as well as the EHE SCIP team. Then we will recap the 5 intensive TA sessions that was hosted with 43 of the 47 EHE jurisdictions and provide some of the themes that emerged during those sessions. As a reminder, we will have a brief recap of our action plan that is being used to guide the development of any programming that you are Then, after that, we will hear 2 examples from EHE jurisdictions that have successfully implemented clinical innovations in their programming. First, we will hear from Orange County, from Orlando, Florida, who will share some helpful information about their jail linkage program. Then we will hear from Bexar County in San Antonio, Texas, about their peer program. So we're excited to have both of you present with us today. And then we will have some time at the end for some questions from the presenters and a large group discussion on key considerations, challenges, and opportunities to implement new clinical innovations in your respective jurisdictions. Finally, we will wrap up and share some next steps, as well as ask you to complete our evaluation. Next slide, please. And so our learning objectives for today are to review promising clinical practices that improve linkage and retention, as well as foster opportunities for patient-centered engagement. And then we want to identify opportunities and challenges, as well as the impact of EHE-funded clinical approaches that enhance linkage and retention. And finally, we also want to increase awareness of jail linkage models, as well as increase awareness of peer programs and processes to increase service delivery across all EHE-funded jurisdictions. Next slide, please. And so now we want to ask you to please, this is our icebreaker for our time today. If you will, please bring out your phones and utilize the QR code that you see on the screen to answer the question that you see on the screen. The question is, if you will, please describe what you're most interested in learning today. And so we know that this webinar is around linkage and retention. And so we want to capture what you're interested in hearing mostly about today. If you will, take 1 or 2 minutes to fill out that Menti. And the way you would do it is to hover over the QR code, and then you would select the web address for Menti, and then you would join by entering in that number that you see at the top and drop in your responses. some good things coming up. Looks like methods and peer programs. We want to hear about barriers. We'll give you a few more minutes to go ahead and fill that out. Successes and contractors. Connections. Retention. Challenges. Thank you all. We'll give you about 1 more second. Awesome. Well, thank you all for engaging in our icebreaker for this afternoon. And we will touch in on some of the things that you have mentioned as what you're interested in learning today. And so we want to make sure that we highlight some of the things that you have already identified in the mentee. Next slide, please. Thank you all. And so now I'm going to provide some background briefly over an overview of NASDAD. So NASDAD is a nonpartisan nonprofit association that represents public health officials who administer HIV and hepatitis programs in the U.S. We serve governmental public health agencies across the states, territories, and local jurisdictions. We do this work by strengthening governmental public health through advocacy, capacity building, and social justice. Next slide, please. And so just a little bit about the EHE SCIP, or Systems Coordination Provision. So the EHE SCIP's team provides technical assistance on the integration of healthcare services. And here are some of the examples of the TA that we provide, including leadership development, learning collaboratives, communities of practice, and peer-to-peer learning. Our areas of TA expertise are listed at the bottom, which include data sharing and integration, program policies and procedures, procurement, subrecipient monitoring and program evaluation, developing innovative programming for key populations, and stakeholder and systems level engagement. So please reach out to us because we do have a plethora of TA expertise that you can definitely tap into. Next slide, please. And here are the friendly faces of our EHE SCIP team. Please feel free to reach out to any of us at any given time to answer any questions, as well as to relay any TA request. Next slide, please. And so we wanted to make sure that we provided space to really talk about all of the work that has went into our intensive technical assistance sessions. So between September 2023 and March of 2024, NASDAD and our partner CAI hosted 5 intensive technical assistance sessions. And these were with 43 out of the 47 EHE Phase 1 jurisdictions. The jurisdictions identify strategic initiatives that are achievable and that will have the greatest impact to focus in on our year 5 of EHE. Some of the common themes that came from the sessions were around stakeholder engagement, clinical innovations, data and monitoring, as well as evaluation practices. And so this webinar series is a response to the clinical innovations theme, and we hope to provide you with tangible and actionable information today that you can take back to your respective jurisdictions. Next slide, please. So we examined the most common requests through our TA efforts in the clinical innovations category and divvied them up into 3 sections, which are access to care, linkage and retention, and viral load suppression. And today we will be focusing on linkage and retention. And then our following webinar, or our final webinar, will center around and focus on viral load suppression. Today, we will highlight promising practices, successes, and challenges that EHE jurisdictions have faced while implementing some of these clinical innovations. And then we want to make sure that we provide space to facilitate peer-to-peer engagement as well. Next slide, please. And so we wanted to make sure that we provided you with a real example of a tool that you can utilize to really implement and move your projects forward. And in our previous webinar, we did share our action planning template. And this template really does outline the outcomes, the procedures, as well as those responsible for moving those projects forward. And so we encourage you to utilize this action planning template as a way to carve out or describe the structure of that programming and utilize that to move that programming forward. And as we did in our previous webinar, we will be sharing out this action planning template post or follow-up of this particular webinar as well. Next slide, please. And so now I am delighted to hand the presentation over to Nicole and Kimberly, who will share about their jail linkage program in Orange County, Florida. So I'm going to hand it now over to Nicole and Kimberly, and we look forward to hearing more from the group.
Hi, thank you, Chloe. I'm Nicole Virtue, the Senior Program Manager here at Orange County, and we have Kimberly Barilla, who's the Senior Monitoring and Evaluation Coordinator. We're going to just start with some information about the program, how it got started, and then we will dive into a little bit more details. So Chloe, next slide. We'll have the program overview, the Orange County Jail information, so our linkage process, outcomes, and some future steps. Just to give you a little idea of our department, we are the Health Services Department in Orange County, and we have all the different divisions, but the most important ones to highlight here is Corrections Health and the Fiscal and Operational Support Division. So Kimberly and I fall under the Fiscal and Operational Support Division, but this program wouldn't be successful without having our partners at the Corrections Health Division. So next slide. And then the highlights in blue, these are all the staff that are involved in our EHE program. So we have our manager here, myself and Kimberly in the middle, and then we have our fiscal folks that help us support us in all the fiscal related activities that are part of the program. So next slide. In our division, although we support all the operations fiscally across all of the divisions in health services, we also have the grants that fall under our division, fiscal and operational support. So we are the Ryan White Part A recipient since 1994. And in 2001, we received the MAI funding. HOPWA, we are the administrative agent for our area, and that's been since 2018. In 2020, we received a SAMHSA grant. It's an MAI initiative, and we're the HIV prevention navigators. Recently, we received the Share Housing Initiative in 2023, which provides rapid rehousing for youth and young adults living with HIV. And we also have our Central Florida HIV Planning Council that heavily is involved in all of our HIV related grants. Next slide. So our Orange County Jail is where we have our jail linkage coordinator, and we'll go into more details about that. But it is a 76-acre compound in Orlando, Florida, Orange County. And it has the capacity to hold up to 4,100 inmates. Right now, we're about in the 3,000 mark. And the average length of stay is 28 days. So if you can imagine what needs to happen within 28 days while somebody gets booked to being released, there's a lot of coordinating that is involved in the process. And in 2023, there was over 33,000 bookings, unduplicated bookings. And in the average the monthly average number of inmates on HIV is 98. So about almost 100 people every month are on HIV medications in the jail. And those are the ones that we've been able to identify. Next slide. Just a little demographic background of the people in the jail. So 53% are Black. Majority of the inmates are male, so 78%. Our average age is 36, and the age range is from 15 to 91, so they do have a juvenile population there as well. And 80% of the jail, people in the jail are pretrial, so they haven't been charged or sentenced yet. And then 83% have felony charges, and less than 1% are juveniles. And then about 1.5% of the jail population has an HIV diagnosis recorded in their chart. Next slide. Just to give you an idea of the process of the jail linkage. So somebody's arrested, and when they are booked into the jail, they are, and I know Kimberly is going to go into a little bit more detail, they receive a reactive HIV test, or if they tell the provider that's going through their booking that they have HIV, that's how we identify them into the jail linkage program. They're then linked to medical care and treatment, and referred to the jail linkage coordinator. So the jail linkage coordinator works, Monday through Friday. And as you can imagine, the jail is 24/7. So people are coming in at all hours of the night. So there's a lot of coordination between when somebody says they have HIV and then linking them to the jail linkage coordinator. The jail linkage coordinator also will complete the eligibility for Ryan White and EHE. And then they follow up to ensure that they're taking their medications every day, they're getting the care that they need with the providers, and they also will connect them to early intervention services. So then from there, that if they have a case manager on file with if they're previously entered into our system, Provide Enterprise, then they connect the client with their case manager, or if they don't, they connect them with early intervention during video visitation, and they sign a release of information and connect them with resources in the community, so that once they are released, then they are connected to services seamlessly. So Kimberly's going to go into a little bit more detail, but next slide. Just a little background, before 2020 at the jail, the Corrections Health, it consisted of some testing if the inmate requested it, and then also they'll continue medication treatment if they were already on it. So HRSA issued the policy clarification notice 1802, which allowed services in the jail. And then we also received the ending the HIV epidemic. So that allowed us to expand the HIV services at the jail. Next slide. And then I'm going to pass it over to Kimberly. Thank you.
Okay. So for implementation in 2020, Corrections Health Services and the Ryan White Part A and EHE programs implemented a plan to expand the HIV services at the jail. We focused on 5 core pillars that included testing, treatment, medication, case management, and post-release coordination. So I'll explain a little bit more on those. The next slide. So for HIV testing, we provide rapid HIV and syphilis testing through a contract we have with a non-for-profit organization. It started in 2021 and then expanded to include syphilis testing in 2023. Testing is offered during the booking process or at any time during your incarceration if you request it. In 2023, we tested a little bit over 4,000 inmates, and then compared to 2018, where we only did 1,700. We recently increased the testing to 7 days a week. And now our monthly average for July was about 565. So we're ranging now between 500 and 700 inmates tested per month. And then to date, from 2023 to now, we've tested 1,900 with syphilis. And we have been able to identify 35 HIV positive individuals that were completely new to the Ryan White program over the 2-year period. Treatment, we initiate treatment based on the Florida Department of Health test and treat protocols. So we provide follow-up care and labs as needed and start them on their ART medications. Our medication is provided through 340B pricing, and we provide treatment training sessions to the providers. So during the implementation phase, we partnered with AETC to provide some training about rapid start to our medical providers in the jail. And our average number of individuals being treated daily for HIV has increased from 50 to 107. So we were able to double that. Medication, as I mentioned, we're enrolled in the Orange County Pharmacy Jail is a 340B program. We recently enrolled the pharmacy in ADAP in June 2024. So we're the first jail in the state to do that. We're able to dispense HIV medication to individuals enrolled in Ryan White and ADAP. We partner with the Department of Health to establish a process to sign up new individuals while they're in jail. So the jail linkage coordinator can do the application with them. And the individual will leave the jail with the medication, their bottle of medication. And as of August, we've had 70 clients signed up for ADAP. So our jail linkage coordinator, it's an EHE funded county position. They are able to complete the EHE and Ryan White Part A eligibility assessments with the inmate while they're in jail. The linkage coordinator has an office at the jail, so she's there full time. She's able to complete the ADAP application. She coordinates referrals for case management, housing, medical services, mental health, substance abuse. She ensures that the clients are adhering to their medical care while they're incarcerated, making sure that they take their medication and labs are ordered. She can upload the labs, medications, and appointments into Provide. She also oversees HIV testing to ensure newly reactives and out of care previous positives begin rapid ART, and she's able to coordinate with case managers and peer mentors to visit the client through video visitation. Our post-release coordination, so when the individuals are provided a backpack when they're released, we put it into their property. So when they get released, they have a nice little backpack with everything they need in it. In there will be HIV education materials. There will be EHE, Ryan White, and HOPL information. We provide them with a $50 food card, a 30-day bus pass. They'll have the contact information for the local health department. We also provide them with an incentive so they can get 2 additional food cards if they engage in medical care. So 1 after each appointment. We provide them condoms and hygiene kit. And then, like we said, they get their bottle of medication if they are ADAP eligible. If they don't have ADAP, then we can give them a 30-day prescription to follow up with the pharmacy when they get released. Next slide. Back to Nicole. Talk about data.
So one of the things that when we are planning this is how do we measure our success, right? And we utilize Tableau as a visualization software, which we all have access. We have Tableau server, which we're able to access dashboards that have been developed. And the good thing about that is that we're able to see data more real time than waiting for us to pull reports and drill down further when we can make some changes right away. So for example, in the dashboard, if we want to see who's not virally suppressed, we can drill down the data and look at the list of clients that are not virally suppressed. And then we can say, hey, what's going on with this list of clients? And follow up on the status to, really work towards ending the HIV epidemic. And we also use it to see how quickly that they're linking to care when they are released, and I know some of the graphs look a little complicated here, but it's just to give us an idea of where we're falling on the map here. We have engaged with 741 individuals in the linkage program since 2023, and 69% of the clients were linked into the medical care upon release. So working with the jail population is very challenging, and there's so much to do within that 28 days. So it really makes a difference to have the data to support so that we can drill down further and utilize that to make changes as we see it. Next slide. And just to give you a little summary, the jail program, it allowed us to identify new individuals and also re-engage those that were out of care. Some of the clients coming into the jail haven't been in care for a long time. And working with the jail linkage coordinator, it gives them the opportunity to access resources that maybe they didn't know about, or things have changed since they were engaging before. Having the EHE funding has really allowed us to enhance the services and make it better. And 100% increase in the average number of individuals being treated. So you saw from the data that Kimberly provided. And we're always looking to ways to refine the program and increase participation. And we're utilizing the data to track the program outcomes. I think that's it. This is our contact information. Back to you, Chloe. Thank you.
Awesome. Thank you so much, Orange County, for sharing around your jail linkage program. It was so encouraging and enlightening to hear your programming and how you've been able to get that program off the cuff with the EHE funding and with other avenues that you have. So thank you so much for that. And I will say that we will hold questions till the end of both presentations, but as we are going through them, feel free to drop them in the chat box and we will be sure to address them after the second presentation. And now I will introduce our next presenters, Nancy and Tanya Mendez from Bexar County, to discuss their peer program. Nancy and Tanya.
Hi, good morning, good afternoon, depending on where you're at. My name is Tanya Mendez. I am the director over our programs area within our Ryan White and Ending the HIV Epidemic program, and I am joined by Nancy Vasquez. She's our program manager for our Ending the HIV Epidemic program. Next slide, please. So just a little bit about what we're planning to discuss today. So a little background about who we are, our peer program overview, kind of how we implemented the program, some of the revamps we did to the peer program, and then we'll conclude with some successes and lessons learned. Next slide, please. So I wanted to spend just a quick moment about who we are. So the Ryan White program is housed within University Health. It's a local hospital system, level 1 trauma center, and so we are the 7th largest city in the United States. Bexar County is the 2nd most populous county in Texas, so we're pretty large here. 94% of the region's people living with HIV can be found in the San Antonio metropolitan region. And just to give you a little context, when we were looking at our 4-county transitional grant area, or TGA, Bexar County makes up about 85% of the population. However, we account for 94% of people living with HIV. And then Bexar County, we've got a significantly larger proportion of Hispanic individuals than both Texas and the United States. So the darker blue in the graph on the right, that is Bexar County and where we're located within Texas. And then the lighter blue region, that is our service delivery area. So I will mention that University Health, we are funded for Ryan White Part A, Part B, Part D, ending the HIV epidemic, as well as a newly funded status neutral approach grant. So depending on which program we're talking about, we've got a slightly different service delivery area. So the 28 counties that are highlighted are kind of the most expansive counties that we serve, both with our Part D program as well as University Health. Our Part B program serves 12 counties. Our Part A program serves 4 counties. So just wanted to quickly mention a little bit about who we are. Next slide, please. So I wanted to kind of shift and spend most of our time talking about the peer program. So what is the peer program? So the peer program is made up of youth in San Antonio, individuals between the ages of 8 to 29 years old. One of the things that we wanted to do is we specifically looked at expanding the youth category. Typically we hear 24 years of age, we kind of transition out of that youth category. But when we were building the EHE program, one of the focus groups that we had really emphasized the fact that individuals 25 to 29-year-olds still needed some hand-holding and support in their care. And so we intentionally expanded that youth population to engage those individuals. So we're really focusing on that up to 29 years old. So our goal for the peer program is to have anywhere between 7 to 9 peers, again, youth between 18 to 29, enrolled in our program. And we really look to have peers from all different backgrounds. So we're looking for, young professionals, individuals who might be enrolled in vocational schools, individuals who might be enrolled in, college or, young professionals. So we're really looking for individuals who have diverse backgrounds from all around San Antonio. So there is an onboarding process for peers, and so that is made up of, an interview, there's an application and interview process, there's trainings that are involved, et cetera. But once an individual is a part of the peer program, the primary focus is really for those peers to identify individuals who are newly diagnosed, out of care, individuals who might be in care but not necessarily virally suppressed. And so the age range that they're typically, talking with are, again, their peers. So again, the 18 to 29-year-old. However, from our data, we've seen that the peer program has also reached individuals who are outside of that. So we've reached individuals who are in their 40s as well, and actually helped to support linking them into care. They're tasked with sharing information about Operation Brave, about the peer program, and really making sure that, they're providing accurate information. So again, we've got trainings that the peers go through so that they're able to provide accurate information. A lot of times we feel information is at our fingertips, but not all the time that information is valid information or accurate information. And so we really want to make sure that the peers are presenting accurate information. We ask them to use their networks to help identify individuals who might be in need of services. I fall outside of that cohort, and, if I'm trying to reach that population, that communication may not resonate as well as somebody who is within that cohort and reaching out to them. And so once those peers identify an individual who might be in need of services, really supporting them and linking them to our care coordinators who can further assist them. That is typically done through a warm handoff, so we really utilize our team here to make sure that that individual feels fully supported through the entire process. I did want to mention that we do have a payment structure that is built into the program for our peers. One of the things that we heard when we did our focus group as we were preparing for the Ending the HIV Epidemic program is youth were tired of having questions asked from them, you know, their time being utilized, their energy, their, you know, information being utilized, and not having something to show for that. So we really looked at incentivizing the peer program by adding a payment structure into this program. One of the things that we also did is we did utilize our peer program and ask peers to be a mixed status group. So we do have some individuals who are living positive and other individuals who are allies, supporters, maybe part of the LGBTQIA+ community. And this was really intentional as well. Again, it was feedback from our focus group, but the other aspect to this is we didn't want to inadvertently disclose somebody's status just by them being a part of this peer program. So we did seek to have a mixed status group so that it didn't matter what an individual's status was, but that they were really supporting individuals who might be in need. Next slide, please. I will mention that we had a little bit of a rough start to the program. You know, as all of you all are aware, EHG got started and COVID hit immediately afterwards. So, you know, we really had a rough start with the program. Our intention when we first developed this program was to have interactions that were face-to-face, in person, really focusing on building relationships, you know, informing individuals and the community that there was this new program, training the peers to be leaders, allies, advocates in the community. And of course, as we all know, COVID halted that, and we really had to take some time and pivot. How are we going to roll this program out with the new landscape that we had? So we really looked at shifting and doing online enrollment. We had pre-recorded trainings that we recorded and then made available online. We had to shift to using a survey platform. We did electronic onboarding packets. We had all of our activities, so kind of those activities that peers engage in to receive that payment, we shifted a lot of that to online. And so, you know, as you can imagine, that was a hefty task to, you know, lift off the ground and, you know, with, I guess, considering everything that was going on. And so it took a little bit of time. We did have quite a slow start to the program. However, as you know, things started to shift with COVID and, you know, we kind of started to come out, we did look to shift a lot of our activities to some of the original intention of the program. We did continue with some of the modifications we made to the program from the COVID era. One of those was including like rolling peer recruitment. So the original intention was to have kind of cohorts where we had a recruitment session, an onboarding session, and then we had peers for, you know, a duration of time like 6 months. When COVID hit, we shifted all that and we did rolling recruitment. So peers could apply for the program and be onboarded into the program at any time during the year. So that was one of the things that we kept kind of moving into years 3 and 4. And so, you know, again, in those training modules that the peers go through, they're self-paced, so they were kind of able to incorporate them at any time. Now I'm going to the next slide, but I'm also going to shift it over to Nancy Vasquez, who's our program manager for ending the HIV epidemic.
Thank you, Tanya. So yes, we have been working with the peers, and so this year is year 5, but these past few years, we've had different generations of peers. However, we always continue that rolling out application. So we always take into consideration like what each peer gives us as feedback. And we also like to apply the learnings that we have from conferences. So we knew that after receiving some feedback from the peers and applying some learnings from conferences that we could take this program to the next level. We began to revamp the program and started applying some of the revamp items to the spring cohort. We like to make sure that we're constantly evolving the program and keeping up with trends, and especially just the youth being our sounding board and seeing like what is that they're able to commit to and are actually excited to be a part of. So as Tanya mentioned, we had rolling applications. So in the spring cohort, we moved, spring cohort, we moved over to having that first official cohort, one specific start date and one specific end date, to allow more of a plan and being more intentional with the experience that the peers would be able to receive with each cohort. Also, another item that we began to do is enhance the peer application. We continuously tweak the application throughout the years, but this spring cohort, we really applied more logic to the application and was able to give a quick eligibility, a quick response to if they were eligible for a program. So meeting the age criteria, being able to commit to the program for 6 months or so, and really defining it as a semester now. Those were some of the items that we've incorporated, as well as a peer retreat. This was one thing that with COVID, we really had to just keep prolonging. And this past spring, we're able to incorporate the peer retreat. It was an idea brought on by our provider champion, and we were able to establish a binder with outlining meetings, activities, and projects that would be happening in the spring cohort, and being able to also have a big experience with them, like bonding, being able to get to know them, and also build community between them. So part of the peer retreat also included a Mythbuster session with a provider champion, allowing more of a one-on-one with the provider champion and answering any questions they might have. We had a Sex Olympics is collaboration with Texas Works Condoms sister grant program that is located here within University Health as well. So also just destigmatizing sex, right? Providing educational information, but also just having fun with it. And then we premiered a Stop the Stigma campaign. That's something that we worked really hard on past year. After surveying San Antonio, we were able to really hone down like what is the stigma around HIV currently in our community. And so we've developed a Stop the Stigma campaign, and we were able to premiere it to the peers and gather their feedback as well. And one of our staff members led a healing circle. The healing circle is a circle of openness, a circle to build trust, and also just building that self-awareness and becoming a peer and becoming an advocate in your community, and using our past experiences to move forward, and trusting our work, trusting ourselves in the work that we do. And at the peer retreat, we also took the opportunity to build direction to peers that were joining us for a third cohort, and what was now a formal cohort, and recognizing staff as well. Some of our collaborators, Texas Works Condoms, and staff members that were present there. Next slide. So brings us to our fall cohort. We're continuing to implement the full revamp currently. And for the collaboration, we really want to make sure that the peers have a good experience with this program. So we have them working with our marketing team, our outreach team. They're very involved in any events that we host. We often do get invited to events with local living positive groups, and we present at the groups there at their meetings, as well as building a toolkit for the recruitment. That's something that we were able to really accomplish for this fall cohort. It was a combination of promotional social media reels, content stories, and then also just events. We had a naughty bingo night to get to know youth. We collaborated with Texas Wears Condoms as well. They have a large following. And we were able to implement some of the social media and promotion items with them as a collaborator. And we also held a speaker session. We opened up one of our current monthly meetings that we have with the peers, and we really invited more community to it. Anyone that was interested and recently applied or was looking to apply to the program, to this speaker session. We had the speaker session, the speaker discussed leadership and the benefit of a volunteer program, and really just create that that skill that lives within them and kind of just develop it a little bit more. And so it was a great attendance for that. And we also implemented a meet and greet. This was something that was new to our recruitment efforts. And the meet and greet really gave us a good insight as to who really was going to come through and on board for our fall cohort. The people that attended the meet and greet was able to get to know one another and begin collaborating with one another and get excited about the new fall. We were able to share some details of the upcoming cohort. We have been very recently doing the in-person onboarding sessions. And so we've already recognized that with this in-person onboarding sessions, we've been able to work on building the community between them, but also establishing the relationship with the new peers and the established peers, and fostering that mentorship aspect of our program. So creating that the opportunity for the established peers to give feedback to them on their elevator pitch, on their presentations that are the teach back from all the modules that they went through on onboarding. And then we're looking forward to very soon start doing presentations at local community with local community groups and colleges and universities. A good combination of that stop the stigma and action, call to action to address the need to stop the stigma in our community, but also sharing and expanding the services that we have here at that at Operation, and really share what is available, because we've noticed that many youth just do not know what local resources are available for them. Next slide. And Tanya, did you want to share a little bit on the success?
Yes, hello. So I'm going to kind of tag team Nancy with some of our successes here. But one of the big successes that we've seen is just referrals coming into the program. So we've been able to show that, having this mixed status group is really working. Our peers have been able to go out into the community, identify individuals, and, help link them to our care coordinator services. So I will, all of the individuals who were successfully linked to our care coordination services were actually linked to care from there, 100% of them. We did have a couple individuals who either declined the service or, might have moved out of our area, and so they were not, kind of enrolled into the program. But we were able to link to care 100% of those individuals who were linked to our navigation services. And so far, we've had 67% of those individuals achieve viral suppression. So, we're showing that this program is working. Of the individuals who are referred to the program, we've had about 60% of those who are male. We've had about 20% who are trans man, and then about 20% who are female. And then as I mentioned the age range earlier, we've had about 80% of the individuals who we've been able to link to care are between the ages of 26 to 40, and about 20% are 41 and up. So we have been reaching a diverse, group of individuals. But, having those first few referrals coming in, I think were a real game changer for us. I will mention that about the split between how many referrals are coming in from those peers who are allies versus those peers who are living positive is about a 50-50 split. So we are showing that having a mixed status group, it doesn't matter what the peer status is, we've been able to have, both groups of individuals referring into the program and being able to identify individuals in the community. So as far as the provider champion, and I know we're running short on time, so I'm sorry about that. So I'll speed it up. But provider champion, we have an individual who is a provider, an MD, and was in another jurisdiction within Texas and actually moved into our service delivery area around the time that EHE first started. And they were really vested in youth education, youth empowerment, really making sure that the youth had a voice in the community. And so she really became a provider champion for us, making sure that the peers had accurate information. If there's, interesting stories or interesting questions coming from the community, the peers had a sounding board to be able to ask questions on a regular basis and having a provider really answer that question. And again, I kind of touched on having that mixed status group and really showing that, that's been effective as well. And I'll pass it over to Nancy to talk about a couple of our other successes.
Thank you. So, the peer program revamp, we're seeing that it's bringing more of an investment from the peers already. We see their excitement about the program when they receive their binders, when they see items are coming ahead for the cohort. So we're really excited to see what this fall cohort brings as well. A Day to Be Brave is an annual event that we have here with Operation Brave. It's a youth event that really just celebrates being brave, whether that is getting into care, sharing their diagnosis, being able to getting out of bed one day. So really just bringing the community. It's a combination of a resource, opportunity for people to have access to local resources, but also just having that sense of support for our youth community as well. Collaborations, like I mentioned, we've been able to collaborate with many different organizations and being able to even utilize influencers for A Day to Be Brave or even our social medias. So that's a little bit about that. People love collaborating with us and we love that as well. Next slide. Lessons learned. So COVID, as well, just due to the COVID, we had to take that time to pivot and restructure some of the ideas and implementation on activities that we had planned. So we're able to move past that. So we're able to just continue with different ideas. Also just building an equitable program from past years. It was mentioned that the two-tier system where 3 activities or 6 activities were not being met a month, and then some activities were not being able to be invoiced. So really just restructuring the program to we have that rolling over opportunity to accumulate activities and not letting any go without being incentivized. So currently we do have up to $500 a month for a peer completing activities, as well as a bonus when connecting someone to nurse care coordination services. Some of the lessons learned as well has been just establishing clear deadlines with the peers. They do have many things going on, school, part-times, this. So being able to kind of share that and deadlines through different forms, and just being able to communicate the expectations as well, outlining a group me message versus an email versus a phone call, since they are collaborating with our marketing staff, our outreach staff. We want to make sure that they are able to stay connected in the best way possible. So, next slide. And here's our contact information. Please feel free to reach out to us if you have any questions. Thank you. Sarah?
Thank you so much, Nancy. Always great to hear about your program. So what we'll do now is, if anyone does have any questions for the presenters, feel free to drop them in the chat. We have a few minutes left here. So while you're thinking of your questions and you're typing them in, we're gonna go to the next slide, please, Zoe. We're gonna do a quick activity. It's really quick, I promise, and painless. It's on Menti again. So you can either use your QR code, you can scan that with your phone, or you can go to menti.com and use the code at the top to participate. And the question is, what is one next action step that you can take in the next week to move your action plan forward? So some examples of things you could put would be work on your grant application. I know you're all doing that right now. Or you could schedule a call with a stakeholder to talk about expanding a partnership, or you could schedule a team meeting, or go over your data and reports, anything like that. We just want to know one action step that you'll take after this webinar. And yes, Darby, we will share the copy of the slides and the recording of the webinar after this webinar. While everyone's typing in their activity, we do have a question for Kimberly and Nicole in the chat. Can you talk about your data sources for measuring the time between referral and linkage?
Yes, so thanks, Van. We all utilize the same database, so Provide Enterprise. So our jail linkage utilizes it. Our early intervention specialists getting clients into care utilizes it. Our case management agencies. So when the client is released from jail, which is actually in our electronic health record at the jail, the corrections health, we have a release date, and we use that release date between the time when there's a lab recorded or a kept medical appointment. So either a viral load or a CD4 or a kept medical appointment. And that's the time between when they're released from jail to actual linkage. I hope that answers the question. Cool.
Great, thank you, Nicole.
And just to clarify, the clients all sign a consent form allowing us to have access to their information. And it says the HIV Care Network, which includes all of our agencies, but it is limited to what agency the client wants to work with. So thank you.
Thank you for clarifying. And I apologize, we ran a little long for questions, but if anyone does have any questions, you can feel free to respond to my message that I'm going to send everyone who registered for the webinar, and I'm happy to connect you with any of the presenters to ask the questions via email if you prefer. Next slide, please. Oh, there we go. Okay, so we want to give a quick plug for some upcoming webinars that we have that you may be interested in. So the first one is part of our stakeholder engagement series, which is on engaging clinical partners. So a lot of the same stuff we talked about today, but will just be from a different perspective. So that's on Wednesday, September 18th at 2 p.m. Eastern. And then the third and final part of this series, which is the clinical innovation series, which will be around viral suppression. That'll be Wednesday, October 2nd at 2 p.m. Eastern. And as always, we have a super quick evaluation survey that we would really appreciate if you could take 2 minutes to fill out. I promise it's only 5 questions. It'll only take you about 2 minutes. We're going to drop it in the chat, and there's also a QR code if you would rather scan that and do it on your phone. You could do that as well. Chloe, do you have that link ready for the Chloe's going to drop that in just a second. So we all have access to the evaluation. So your responses to our evaluation really do help us improve for future webinars. So we really appreciate if you can fill that out. And I will also follow up with it in the follow-up email as well. And Chloe just dropped that link in the chat. Next slide. Thank you. So last but not least, I want to remind you that NASDAQ is here to support you with TA. So feel free to reach out to any of us, any TA needs that you have, especially around the topics that we discussed today. So I'll follow up after this with the slides, the recording, and since we didn't have time for questions, I could go ahead and include the contact information as well for our presenters in case you would like to reach out with any questions. And we'll see you all next month, hopefully, for part 3 of our series on viral suppression. And thank you all for attending. Have a great rest of your day.